Three, two, one. We are live.
Thank you. A very good evening to all of you. I, on behalf of the Indian Society of Cornea and Keratorefractive Surgeons, welcome you all in this yet another webinar on something which is really tricky, a couple of things which are really very important in our day-to-day practice. And we will just see from our experts how they handle these. We have with us Professor James, President of ISCRS and Chief of RP Center, who has loads of experience in terms of his publications, in terms of his surgeries. He was the first Indian to have performed live cataract surgery at ASCRS. He has numerous awards to his name and most coveted Padma Shri from the Government of India by the President of India.
We have with us Dr. Rishi Mohan, who is the Vice President of Indian Society for ISCRS, and he's an RPC alumnus who's passed out from RP Center. He was awarded the membership of Academy of Medical Sciences in 2006, and he did a 5-month training in phaco from Prince Charles Eye Unit, King Edward Hospital, UK. He has to his credit several academic awards, and he's held several positions in various societies, which include the past president of Delhi Ophthalmological Society, the secretary of ORA, the joint secretary of DOS, the member scientific committee of AIOS, the treasurer of Eye Bank Association of India, the member scientific committee of AIOS, member managing committee of AIOS, and also has been in several positions at Eye Bank Association of India. And we welcome Dr. Rishi Mohan.
We also have with us Dr. Rajiv Mukherjee, who is the treasurer of ISCRS and director and senior consultant in Mukherjee Eye Clinic. And he is also a visiting professor at Feinberg School of Medicine, USA. He is an established cornea and phaco surgeon and has loads of experience in the field of cornea and cataract surgery. So we welcome Dr. Rajiv Mukherjee.
It is a pleasure to welcome our good friend, Dr. Vinay Pillai, who's senior consultant and head cornea and refractive surgery services in Trivandrum. He's done his MBBS from Government Medical College, Trivandrum, DO from Regional Institute of Ophthalmology, Minto Ophthalmic Hospital, Bangalore, and DNB from Chaitanya Eye Hospital and Research Institute, Trivandrum. He has worked previously in Chaitanya Eye Hospital, Shankar Nethralaya, Chennai, and LV Prasad Eye Institute, Hyderabad. He has a special interest in ocular surface disorders and corneal stem cells, K-Pro, ectatic corneal diseases, high-risk corneal transplants, and pediatric corneal disorders. And he's participated, presented, and lectured on many scientific topics in international and national conferences, including ASIARO, APO, etc. He's published several articles in the peer-reviewed journals, and he's currently working in Girdhar Eye Institute in Cochin. And I think we all know him as one person who started keratoprosthesis in a very big way in Chennai. And I think all of us have learned something or the other about ocular surface or K-Pros from Dr. Vinay Pillai. So welcome, Vinay.
We also have with us Dr. Gautam Parmar, who is the head of the cornea and refractive surgery services at Sadguru Netra Chikitsalaya, Chitrakoot. He is expert in the field of cornea, refractive surgery, and cataract, and has 5 publications in peer-reviewed journals, which includes his wonderful publication that is stenciling-based prick and print technique for harvesting shaped corneal grafts. And he has won many awards, and just to name a few, he also received the Young Achiever Award in 2017 by ISCRS, and has also received the Best Video Award for stenciling in ophthalmology in JAM session in Keracon. A very good surgeon, a very good clinician. We welcome Dr. Gautam Parmar in this webinar.
Thank you.
It is a pleasure to welcome Dr. M. Vanathi, whom personally I have known for years since we've been in ophthalmology together. She did MBBS from the prestigious Madras Medical College of Madras University, Chennai, MD Ophthalmology from RP Center, AIIMS, New Delhi, senior residency again from RP Center, AIIMS, New Delhi, and has done her international clinical fellowship in cornea from the renowned Singapore National Eye Institute, Singapore. She's currently working as professor of ophthalmology in the cornea and ocular surface, cataract and refractive surgery services at AIIMS, New Delhi. She is the co-officer in charge for the National Eye Bank Services. She has more than 80 indexed international publications. She's on the editorial board and a review of several national and international scientific journals, and has contributed to many scientific papers and has participated as faculty in several national and international conferences. She also has, she's also a great leader. She's been the past secretary of the Delhi Ophthalmological Society, and is also part of the managing committee of All India Ophthalmological Society currently.
We also have with us Dr. Chintan Malhotra, who is working as professor in the cornea, lens and refractive surgery services at Advanced Eye Center, PGI Chandigarh. And she is currently also the honorary secretary of Chandigarh Ophthalmological Society and member managing committee of AIOS. Her area of interest are keratoconus, corneal imaging and diagnostics, refractive surgery, corneal infections. She has more than 75 publications in international and national journals and has been reviewer for many reputed journals, which includes the ACTA, Ocular Immunology, European Journal, etc. And she has been very active in academics and has presented various lectures, both nationally and internationally. We welcome Dr. Chintan Malhotra in this webinar. And of course, we have with us Dr. Namrata Sharma, who is the Chairman Scientific Committee of ISCRIS and also the Professor of Ophthalmology in Cornea, Cataract and Refractive Surgery Services at RP Center. She is also the Secretary of AIOS, Regional Secretary, Asia Pacific Academy, and Secretary of Eye Bank Association of India. She has numerous publications, more than 500, and various chapters, many textbooks, and has been very active in academics. We welcome Professor Namrata Sharma in this webinar as a co-moderator. And of course, myself, Dr. Rajesh Sinha, Honorary General Secretary, ISCRIS, and Professor in the Cornea Services at RP Center, AIIMS. So before we actually start the scientific presentations, I will request our President, Professor Titial sir, to say.
Yeah, thank you, Rajesh, and good evening, friends. Indeed, it's very heartwarming that we are in a webinar today and looking into the two subjects which have been chosen by Dr. Rajesh. It seems that it is totally cornea-centric practice-wise. But looking into the first topic, which is glue in ophthalmic practice, not only cornea surgeons or corneal practicing ophthalmologists, for general ophthalmologists also, it is of great use because it can really save the eye. You can save the day for a person. Similarly, looking into a keratoplasty, controlling astigmatism, is a subsequent after surgery which has to be seen by not only by the surgeon, him or herself, but unfortunately in our country, patients come from different parts of the country and approach may be very difficult for these patients. So our general ophthalmologists may have to learn these techniques also, or know the particular issue and refer them to proper place. So both topics have a huge significance to a general ophthalmologist as well as for a cornea practicing people also. Rajesh has chosen, and I'm very happy they accepted to be speaker today. Professor Vanati is a very experienced corneal surgeon with us. And Dr. Binay, we all know he's one of the leading cornea practicing in India. And whatever work he's done, people really follow his work. And he has the huge practice behind him. So both of them are going to give us very, very practical points in these important topics. And two expert discussing, Professor Chintan and Dr. Gautam. Both of them are equally experienced and senior people. I'm fully aware that their discussion will give us some points to take away. Looking into ourselves, Rishi, myself, Namrata, Rajesh, we are also going to gain a lot of things from these two discussions. So let's hope that we have a very good discussion today of these two important topics. Thank you, Rajesh.
Thank you, sir. So we begin the scientific session, and the slight change. The first speaker will be Dr. M. Vanati, and she'll be talking on managing post-keratoplasty astigmatism. Dr. M. Vanati.
Yeah. Thank you, Rajesh, and thank you, sir. It's lovely to be part of this wonderful webinar. Am I audible and visible?
Yeah.
Yes. Okay. I have no financial interest in the mention of any products or other devices during the course of this talk. Post-keratoplasty astigmatism exists in over 30% of our patients at least here, with a quantum being higher than 5 diopters here. And about 10 to 20% of them may not be amenable to the routine optical correction by glasses or by contact lenses here. So this is one of the most important concerns in the management of keratoplasty following surgery here. I'll delve about the basic aspects which one needs to be aware of when you're tackling post-PK keratoplasty or post-keratoplasty astigmatism. Sorry. So to begin with, assessing the topography pattern following your keratoplasty is imperative in understanding what is going to be the result of the interventions you're going to be performing here. So most of us know the common topography patterns which we would usually get from a symmetric or an asymmetric butti, the oval or round steep central corneas here, apart from the irregular patterns here. Indication wise, what are the effect of the indications, the preoperative indications, and what are the intraoperative problems which one needs to be aware of, so that we could avoid the higher extent or higher magnitude of keratoplasty astigmatism is very important when you're looking to begin with. Please understand that when you're looking at indications such as keratoplasty, such as keratoconus, your postoperative astigmatism quotient is probably going to be higher than something that you would perform.
Admin, there's some noise, Dr. Vanati. Just admin, there's some noise from the background. Can you mute everyone else?
Is it okay? Yeah. So when you're doing a keratoplasty for something like a DALK or a PK for a keratoconus, please remember the quotient of astigmatism is probably going to be higher than that what you would do for a small simple central scar or for a dystrophy patient here. And remember that the irregular astigmatism component, if it's higher on the patient you're going to start with, you're going to carry a part of it into your postoperative period as well here. So these aspects need to be considered when you're considering the kind of case you're taking on for doing a keratoplasty. The important aspects in the interoperative concerns is, as listed here, the use of Fleringer rings. To tackle this, you have several surgeons who do loosen their Fleringer rings or untie their Fleringer rings during the course of their surgery, so that the effect of the surface of the globe distortion by the Fleringer sutures can be minimized here. One of the most important aspects is getting a perpendicular cut down and a good centration using your Trifine. Oval eccentric centrations or non-perpendicular cuts of the triffination mark is going to be one of the leading concerns, which results in a lot of residual astigmatism here. When you're looking at graft sizes, the disparity of the grafts and the small size of the grafts, the closer you're going to move your grafts to the optical center, the higher is going to be your quantum of astigmatism here. And when you're looking at graft host disparities, commonly we have all moved on to a 0.25 mm disparity here. But when you're doing higher than 0.5, especially in certain special situations where you would need to use either the same size grafts or higher than 0.75 or 1 mm disparate grafts, beginners will need to be careful, and this would result in a higher astigmatism if you're not able to match your sutures properly. Again, disparity in the thickness of the of the graft between the graft and the host is going to be another common reason, especially as in cases as viral keratitis, where you could have peripheral thinning or enlarged cones of keratoconus. These again are going to be concerns where they could lead on to a higher astigmatism. Of course, the most important is the kind of suturing technique and the amount of suture tension your arm is placing on the sutures when you are doing a keratoplasty is perhaps going to tell you a lot in the residual astigmatism you need to be managing. Of the common additional procedures which are going to influence is the secondary IOL implantation of performing scleral fixated IOLs here, which are going to again have a higher quantum of astigmatism when combined with keratoplasty procedures. So it's imperative that these preoperative and the intraoperative concerns are tackled optimally in order to obtain a good or the least amount of post-keratoplasty astigmatism. There are a few case examples of decentered grafts here or improper cuts, as you would do perhaps in tectonic keratoplasties or in corneal ulcers, where a complete refination is usually not possible, and one needs to be wary and look at a higher quantum of astigmatism in such cases. It's a very simple diagrammatic representation, which I always do point out to my residents. So this is perhaps one of the most important aspects when you're placing your suture from your graft to your host here, and you place it at the same depth, the same plane, and at an equal distribution of the tension of the suture on the surface of the cornea, which is probably going to be the most important in controlling your postoperative astigmatism. When you look at suturing techniques here, there are various combinations of suturing, interrupted being the most common, followed by most surgeons, and combined suturing with eight interrupted and single continuous, or a double continuous sutures here, a talk pattern, a no talk pattern, or an anti-talk pattern here. So whatever one follows here, it basically is going to depend upon what the surgeon is most familiar with. But please do remember that all these three techniques of suturing, the talk, no talk, and the anti-talk, do finally result in a similar quantum of astigmatism here once they are removed following the first 6 months, but do offer a particular advantage in that you could probably adjust your suture-induced astigmatism by rotating the sutures depending upon how your topography pattern prevails here. Again, I'll get back to what I said on understanding the topography patterns. Do always remember that prolate patterns, which are most frequently seen after single continuous suturing, and that's what is going to be placing your corneal topography closer to the physiological pattern. And again, what we all aim in suture adjustments is to achieve as near prolate as possible when we are doing our suture-related managements here. Tight suturing such as this is particularly common in beginners and in therapeutic keratoplasties, where such tight suturing induces a significant amount of surface irregularity and a flattening of the graft because of the squeezing of the graft tissue on all sides on 360 degrees when the person is suturing. So this is something beginning surgeons need to take care that you avoid such kind of suturing for obtaining optimal results here. The other common consideration, the common questions is that how long do we keep the sutures in, and what exactly is going to be the right time to remove the sutures here. And I think all of us do agree there is no standard protocol, or there is nothing standardized which would tell you. But something which most of us surgeons do follow is we keep our sutures in for as long as you can keep them and for as minimal astigmatism as you're able to obtain with your sutures in. So that's something which we'd all like to follow up, but I also add on the quotient of assessing if the patient is able to follow up with you considerably at a considerable period of interest. You're able to assess the suture-induced problems which can occur in these patients, because suture-induced concerns are perhaps going to be the top leaders in leading to graft-related concerns such as rejection and graft infection here. So when you find that your patient is not able to follow up with you, I do think about managing or taking out these sutures probably earlier than 6 months or so. Yeah. So loose sutures, vascularized sutures will have to get out as soon as it is possible to take them out here. When you're managing suture adjustments in interrupted suturing techniques, then selective suture removals, I would commonly prefer to do as long as the graft has stabilized, the edema has gone away, the topography is stabilized. So reasonably, we would look at a period of 2 to 3 months or 3 months when the topography stabilizes. And that's when you would probably want to adjust your sutures or replace your sutures. But in the event that your immediate postoperative period in about 3 to 4 weeks is showing a higher quantum of astigmatism, and then you could probably take your patient in earlier to replace a particular sutures to reduce the quantum of astigmatism here. Again, when you're looking at suture removals over 6 months period here, what is commonly taught to our residents is don't remove all the sutures in one go, do alternate suture removals, wait for the surface to stabilize, take them back in about 2 to 4 weeks to remove the residual sutures here. But I think each patient is going to need a custom approach to manage the suture related problems which you are going to have in these particular patients. And it's not that one is going to be applying to all. When you're looking at pediatric keratoplasties, then you would probably look at an earlier suture removal. But that said and done, there are several times you will probably have to redo your sutures once removed as well if you find that your quantum of astigmatism is reversing following your suture removal. Again, do remember that every episode of a suture removal is attached to an increased risk of infection or rejection. So manage appropriate for appropriate time with antibiotics and steroids as required here. Topography assessment using a computerized video keratography using your Scheimpflux method is quite adequate or quite appropriate in managing. And if you do lack one, a simple keratometry will also help you to aid to find out the flat and tight and the steep axis here. But for looking at a good topography pattern, it is really imperative. And again, remember, suture adjustments give you best results when you're looking at a prolate topography or when you're looking at regular astigmatism, at a significantly regular astigmatism. And both type patterns are the ones which respond optimally to suture management adjustments here. A few case examples here when you're looking at the topographies of the cornea following keratoplasties. Do apologize for the older slides as I'm in isolation and was not able to go back to retrieve my latest presentations here. But serial topography assessments are one fantastic way of understanding the astigmatism quotient of a patient and how you would really use your suture removals wisely to manage these, or would like to replace some of these sutures to manage the astigmatism early on. By and large, optical correction with glasses and contact lenses still remain the mainstay in the role of managing post-PK astigmatism here. When you're moving, many of them do need contact lenses here, and we have a lot of good contact lenses right now. We have the lenses which are specific for use in graft cases, post-keratoplasty lenses, as in the special type with Roske, and of course the mini spiral lenses work wonderfully well when you're managing a higher quantum of irregular astigmatism in these cases. But again, it is imperative to assess the topography pattern of the cornea in order to understand the best lens design, which is going to be optimally fitting these patients, and perhaps best done after the sutures are all removed, and give a 3 months period for the topography to stabilize before you would take these patients on for the contact lens fitting, and also to assess their ocular surface here before you're fitting them on with the contact lenses for visual rehabilitation here. When would you like to intervene in terms of suture removal in most of your patients? Here is wait for a complete graft host healing to have occurred, wait for the corneal surface to have stabilized, take into consideration aspect of the age, the effect of topical and systemic immunosuppressive therapy. So it's best that the patient has a stable ocular surface under a minimal immunosuppressive therapy before you're aiming to manage these concerns with sutures or with contact lenses in these patients here. A complete evaluation will comprise of a comprehensive slit lamp biomicroscopy, good refraction, topography, pachymetry, aberrations analysis, and a specular microscopy here. So what are the surgical options which we have in managing keratoplasty astigmatism here? So the list can be long with a combination of several aspects, with many new aspects having come into play. Incisional keratotomy, relaxing incisions, augmentation here, compression sutures, and wedge resections. Not done in most cases, but may be helpful in very high quantums of astigmatism. Laser refractive interventions in form of single refractive laser cuts, or with the sequential cut and an ablation. Intrastromal corneal rings, those are not the best method in post-keratoplasty astigmatism. In older individuals with the association of cataracts, then you could use toric IOLs for management here. Younger patients, phakic IOL, considering if the topography is reasonably stable with a good amount of regular astigmatism. And of course, regrafts is not something which we would probably look at, but when you're looking at regrafts, we are looking at when most of us are doing endothelial keratoplasties, looking at the surface astigmatism is one particular concern in the visual rehabilitation of custom lamellar component surgeries here. So it's only the astigmatic component which would be tackled by the incisional keratotomy. If the defocus component of myopia, hyperopia also needs to be tackled, well, then you will need a laser ablation, topo-guided surface ablation, along with the use of mitomycin C, depending upon the quantum of ablation which is required, is what is going to give you best results here. Phakic IOLs, piggyback IOLs are all other options, but the long-term results of how these are going to be favoring or being stable and predictability is what we are going to be concerned with. Again, when you're looking at incisional relaxing incisions, what I do primarily find is that the stability or the long-term predictability of these incisions are perhaps not going to be as great as you would have in any other options here. The astigmatism tends to recur. The predictability is particularly low, as you do not have any particular or a standard nomogram to follow, with the danger of dehiscence and topographic instability, perforation, or all other aspects here. We do have now with us the ability to use paired femtosecond laser assisted arcuate keratotomies on the steep axis in keratoplasty cases, which can go up to a 90% depth, and results literature has shows that the correction can range from 2 to 7 diopters and can remain stable. But it's again the same concerns of the predictability being particularly low, and the stability of how long these corrections are going to last. The concerns of overcorrections, the occurrence of allograft rejections, and inducing higher order aberrations are all concerns when you are adopting femtosecond laser assisted relaxing incisions in these patients here. Large quantum of astigmatisms, you could use a combination of relaxing incisions along with augmentations using sutures here, and they are associated with inducing some amount of hyperopic and myopic shifts in these patients. So by and large, something which most of us like to do or do adopt in most of these cases is a topo-guided surface ablation with or without intraoperative mitomycin usage, which perhaps is going to give you the best results of the fast visual rehabilitation with a decreased scarring, with a minimal regression, and you have the advantage of being able to correct a large amount of refractive error with these patients here. Sequential LASIK is what I mentioned earlier, is just doing a flap cut, and that this procedure was initially described from RP Center. and results have shown to just a simple flap lamellar cut is shown to decrease a certain amount of a significant amount of cylinder in the initial phase, and following 2 to 3 months later, you could take on for the flap lift and an ablation here. Concerns now being that most of us are quite hesitant to do a flap cut on a keratoplasty, especially a penetrating keratoplasty cornea here. So that particularly is a limitation in you trying to do this lamellar cut procedures. Wedge resections are largely historical. That said and done, perhaps this is one of the best if you're looking at a large content of astigmatism, especially in cases of pellucids here, which have been managed by lamellar or penetrating keratoplasty. And you have to place the wedge resection on the flatter axis. And the quantum of astigmatic correction can vary largely, can go up to 8 to 12 diopter astigmatisms, but does induce a significant amount of aberrations, the risk of infection, risk of perforations, the risk of rejections, and a very high unpredictability in the postoperative results. Do not encourage most of our surgeons to use this here. Using toric IOLs in the age group, which is associated with cataract, gives excellent results in managing post-keratoplasty astigmatism in these cases here. Phakic IOLs, you can use them for younger patients, and do be sure that your topography is stable and you're able to give you optimal results. But do warn your patients, it's not going to be as well as the results you would get when you're using phakic IOLs for virgin astigmatism corrections here. Always looking at the topography of the graft does give you a fair amount of idea of how you could expect the results of your astigmatism management in these cases. I think I will quickly run through a couple of these examples. Again, these are case descriptions just in the interest of time. These are just examples to show how the astigmatism does generally change over a period of time with your sutures in, with your sutures out, can be unexpected the way they behave. So that's something a surgeon needs to be prepared for. It is a battle which is long drawn and which has to go on for a larger period of time. We do have the advantage of using the intraoperative aberrometry now when you are planning cataract surgeries following lamellar procedures, following penetrating keratoplasty. But when you are using the ORA for placement of intraoperative toric IOLs here or for rotations, do remember that the surface interface, the interface over the surface does perhaps does not give you a predictable or a reliable amount of imaging as you would do it for routine cataract surgery. So that's a particular limitation, and sometimes your imaging is not as well in these patients. And there are scenarios when you probably will have to take your patient on for cataract surgeries within your 3 to 6 months period with your sutures in, with a reliable amount of astigmatism, especially if they are one-eyed, for visual rehabilitation. So that is also something which most of us have done in all our patients. And to conclude, something which is in now is the neutral TCAT, the topo-guided custom ablation topography for our patients. Again, works well if your quantum of astigmatism is reasonable, is something less than 4.5 to about or 5. It usually does not work with astigmatism which is higher. With astigmatism associated with a lot of surface irregularities, you will have to look at your C4, C12 decompensations in these patients. And what I have seen in the small group of patients which we did do at RP Center is that the reliability is not so great here. And there seems to be a regression in these patients when they do tend to get back their astigmatism probably 6 to 12 months down the line. So those are particular limitations when you are using neutral TCAT in the management for post-keratoplasty astigmatism. I think I will stop here and thank Rajesh for the opportunity to share part of my experience with all of you. And thank you once again. It's been wonderful being here with all of you.
Thank you, Dr. Vanati. It was almost everything you have covered, very nicely covered this topic. And I would like to have comments from Chintan Malhotra on this important topic.
Thank you, Dr. Rajesh. And I think Dr. Vanati left no aspect of the post-keratoplasty astigmatism untouched. One thing which just for the people who are listening, I'd like to emphasize is that astigmatism, I think post-keratoplasty astigmatism is actually handled intraoperatively the best. If we can take intraoperative measures to reduce the astigmatism, then our later on problems become much less. At least for residents I've seen as they start, they don't realize so much as the importance of the 6 o'clock suture. So that is the one which probably determines your distribution of the tissues. And that's something we need to know, that that's your 6 o'clock suture. If that is correctly placed, it helps to distribute your tissue and your tension well. Also, rotating the graft, like once we've taken the graft and we rotate it intraoperatively before starting the suturing to see how it fits into the wound. And you see, if you have an intraoperative keratoscope, to see that you're getting circular Meyers before you start suturing. Probably that also helps in reducing the astigmatism postoperatively. And so I think those are suture manipulation at the end of surgery. If one doesn't have access to expensive intraoperative keratoscopes, one could use very simple devices. I mean, for the end of a safety pin, which gives you like a little bit of a circular Meyer or other circular devices which act like a Placido disc, because not all of us may be having these expensive things. Although if one has an intraoperative keratoscope, I think that is the best, the way that's seen. And suture removal is, ma'am already mentioned, best started. It should be as early as possible, but not so late that your wound has healed and it doesn't correct your astigmatism. I mean, people do mention starting it as early as 2 months, but I usually do wait for 3 to 4 months, at least the end of 3 months, because I've seen that sometimes patients do tend to have a little bit of graft dehiscence. The wound doesn't heal so well. So I normally don't start suture removal before 3 months at least, and then within 3 to 6 months one can just stop. So I think lots of things to go on about, but I'd maybe have the opinions of the other panelists on the other aspects as well.
Thank you, Dr. Chintan. Sir, Tityal sir.
Sorry. I think most of the things are very nicely covered and beautifully highlighted also. As Chintan has also stressed that I think the intraoperative measures may be the most important aspect for getting the good outcome. That will definitely would be based on the type of patient we have, the indication of keratoplasty, and nothing is important than a proper training of a surgeon in terms of doing a keratoplasty. Nowadays, we do have access to a good wet labs where people can train themselves for appropriate suturing techniques. All days we all train patients directly. We didn't have a wet lab, but now we have a wet lab where people can train themselves in doing appropriate suturing, because the entire other side of ophthalmic surgery like cataract, people have become sutureless. So sometimes they go for a keratoplasty, they can't really put the in-depth sutures, and the amount of suture which has to go through from the host and from the graft is very difficult to titrate the people who are not trained. So I would appreciate people should get proper training in keratoplasty techniques, that is making the host bed, the graft orientation, suturing techniques, as Bharati beautifully showed the different suturing techniques, and assess themselves post-op by looking into host graft junction. I think one or two the slide I saw from Bharati where we could see the entire cornea in a anti-segment OCT, and you could see the entire host graft junction, and the anterior posterior apposition is very important, because that's going to decide the outcome of your surgery as well as the post-op outcome of whatever correction you're going to do. If your host graft junction is not appropriate, whatever we do, your results are going to be very unpredictable. If a very nice apposition, then the surgical technique will be good, and even a management post-op will be much better in these cases. Other important thing which talked about is intraop keratoscope or aura. I'm pretty sure I've never used them in my own period of being in a cornea, and that as such doesn't really change your post-op outcome. It is your surgical training and your own experience that's going to matter in the actual outcome in the subsequent time. So I would say training is very important, and assessing your cases subsequently, that you realize which suture is major problem. Like suppose many people will have, as you rightly pointed out, 6 o'clock. More than that, 3 and 9 o'clock sutures are very tough for people who are not used to a keratoplasty, the beginners, because those sutures can really cause difficult orientation of graft in terms of a host and graft opposition there. And other areas of concern is when to tackle these patients in the post-op period. So you have a early tackling, intermediate, late, depending on what type of sutures or what type of tightness, looseness you have, especially if you are looking for therapeutic grafts, your quality of graft tissue may not be good. You may be thick on the table and your suture may become very loose immediately. So you have to take these patients early for a suture replacement. But I know that tackling astigmatism post-keratoplasty is one of the most tricky areas. Whatever you do, never get the the thing which you are thinking never comes out exactly in many patients. So you have to be very I think you should have proper counseling of patient. Tell them you may require multiple sittings. The first sitting may not give an appropriate outcome. Sometimes I've seen the graft getting totally dehiscent, and you have to do a resuturing in these cases. And in some of the cases people have described in a large area of astigmatism, sometimes you have a difficult opposition. You can refashion the graft, host graft junction again to get a good outcome in these patients. But in the long run, I think most cases do well. You have to give it time. Let it settle down. Don't jump into doing something in a very early phase of a keratoplasty. You see these patients after 6 months to 1 year, the astigmatism goes down. And many patients will accept the around 3 to 5 diameter cylinder without any difficulty. And most of our patients come with such a poor background, poor ocular surface. Whatever we do, that's going to deteriorate the graft functioning, both ocular surface wise and graft rejection, what Dr. Banaji talked about. So these are very important things. And identifying the culprit is also very important, especially a loose suture, tight suture. That can be picked up by the one drop of fluorescein in the ocular surface will give you all the information you want of host graft junction and sutures. And video keratography is of real help. If you have access to a good AOCT, that again going to give a lot of inputs for how to refashion your subsequent correction for these patients. But I would say normally if you retain the suture for 1 year and the sutures are buried, and surface looks all right, so contact lens rehabilitation the best way to rehabilitate these patients, and that's going to give a best outcome. But if you think your sutures are not buried, you might remove the sutures. Those sutures are going to make a difference. Otherwise, you can leave the sutures and continue contact lens practice in these patients. I think long run, most patients do well, but there are some issues which is very difficult to tackle. I just remember one case before I close this thing. So I had lamellar keratoplasty for one gentleman and dark infect, and he developed cataract subsequently. I did a cataract, put a toric IOL for that patient, and he regained good vision. After 3 years or so that he graft, had a recurrence that he was a patient of granular dystrophy. Then I had to refashion the graft. So I could refashion it. But then now the new astigmatism was totally opposite to the IOL which I put. And patient never gained a good vision. And I'm waiting for last 2-3 years to modifying the astigmatism by putting sutures, taking away sutures, and having a very tough time. So putting a toric IOL in a post-keratoplasty patient is also a challenge. We have to look into that aspect very, very carefully. And I'm pretty sure other premium IOLs will be very difficult in these cases.
Thank you, sir.
Good presentation.
Thank you, sir. So we'll just move on to the next presentation, and then after that we can have a detailed discussion on both the talks.
I can ask one question to Dr. Namrata regarding what Banaji talked about PRK onto the surface or making a flap. Because PRK, I don't think it's going to work in most of the keratoplasty patients. What about flap making? Because you are part of that publication from RP Center.
So it does work, sir. Only thing is you have to do a two-step procedure. And we've tried to do earlier with the microkeratome when there was not too much of a problem, because that would encompass even the graft host junction, which was whitish if it got scarred. But even with the femtosecond procedure also, it is possible to do it. And you do it as a two-step procedure. The only thing is that, and the advantage is that if we compare it with the surface procedure, the chances of regression are far less as compared to LASIK when you do, especially post grafts. So that is one advantage. Only thing is you cannot probably address more than 4 diopters of astigmatism, because that would be the amount that you would, a couple of diopters do go away because of the flap that is created, and then by the laser not more than about 4 diopters, because that is all that the laser will allow you to do, because otherwise the cornea will become keratoconic. So that is the thing. Otherwise it is a very good procedure. In a couple of aberrant cases we had very fantastic results, in the sense that the moment we released we created the flap, there was a decrease in astigmatism of more than 4 diopters also. But those are just odd cases here and there. So if you are
Okay.
looking at astigmatism of about, say, 6 diopters or 7 diopters, I think that is a good procedure to do.
What about the host graft junction giving way in while putting so much of suction pressure?
So it has never happened with us. The
Okay.
only thing that has happened is, has been reported also, that there is a slight graft retraction which has occurred,
Ah.
because at the area where the graft host junction is and at the area where your flap is, so there is a small crescent that got
Okay.
created in one case. So we reported that case also, but otherwise, as such, because of the suction ring itself, or because of the suction ring of the microkeratome or of the femtosecond laser, we've not had as such problems with the graft host junction.
Okay.
We had taken
Just-
9.5 millimeter suction
Yeah.
ring in the
Larger
series.
one.
Always
Yeah.
take a larger one for these.
Yeah.
The last question to all of you, like Dr. Amar talks about, tackling very high astigmatism, totally aberrated cornea. Would you do a pinhole pupilloplasty in these cases? Dr. Vanati, you are also from Chennai.
Not really, sir. I think we would not want to do an intraocular procedure for astigmatism, and in such patients, I wouldn't delve into it for astigmatism.
Yeah, Namrata?
Sir, I think if you can tackle it on the cornea itself,
Okay.
it is a good thing to do. And pinhole pupilloplasty, possibly in some odd patient who doesn't want a corneal, who doesn't want a flap procedure or something like that. But I don't think, personally, I don't have too much of experience on it. And
Yeah, just so
as
Vanata,
cornea people, I think we are a little wary of
Yeah.
addressing
I
astigmatism.
just saw
at the
one
level of the-
slide from Amar only, a normal Fuchs patient,
Mm,
and he's done a PDEC and a pinhole pupilloplasty.
mm.
So that's going too far away. Okay, anyway, I think that's maybe one way to tackle totally aberrated corneas. Okay, Rajesh, sorry, taking longer.
No, not at all, sir. It was a good discussion, actually. The paper that you were telling, I also remember, because I was part of the.
You've written that.
Yeah, I had written that. And the
So
average.
yeah. There were 2-3 studies actually in
Yeah.
that, which had
Yeah.
come one by one, and then finally we did a survey article
Yeah.
post keratoplasty astigmatism management.
I think that would be better than doing a arcuate keratotomies, because that
Yeah.
doesn't work at all. It's like making a
It's like making a
total-
big keratotomy.
Yeah.
big keratotomy. Okay.
So we move on to the next talk, and we have Dr. Vinay Pillai, who will be discussing about a very pertinent topic, very good thing that has come up, that is glue in ophthalmic practice. So let's listen to him regarding what all he has to say about glue in ophthalmic practice.
Good evening, everyone. It's an honor to be here. Thankful to Dr. Rajesh Sinha, TTL sir, and Namrata Sharma madam for inviting me to give this talk. Now, I have no financial interest in any of the products mentioned. In this era of pandemic ravaging through our country, managing a corneal emergency at times can be very difficult because of the lack of accessibility to required things like corneal tissue, and even for patient to reach a specialized center. And tissue adhesives come into play, a big way here, especially in our present times. So it has been described in various surgical procedures, and in ophthalmology, the use of adhesive was first documented in 1950 with the use of human plasma. Tissue adhesives, or glues as we commonly call it, can be of synthetic nature or biological derivatives. Synthetic adhesives can be, or the common ones which are available is the cyanoacrylate glue or its derivatives. Polyethylene glycol glue has also been described. Now, cyanoacrylate glue, the first one to be tested was a methyl 2-cyanoacrylate, and over the time period, it has evolved into various, different types of cyanoacrylate derivatives. And the most recent one is supposed to be octyl derivatives. The advantage is just much more flexible, but it has got much less tensile strength than the butyl derivatives. So how does it act? These are actually liquid monomers of cyanoacrylate, and they rapidly polymerize into solid polymers in the presence of anions. And presence of moisture actually speeds up the process of polymerization. Again, when we apply thin layers, those polymerize faster than putting a thick, cyanoacrylate glue onto the area of interest. The procedure is mostly done under topical and can be done under slit lamp or in minor OT, depending upon the condition where we use it for. The most important thing is the surface where we have to apply the tissue glue has to be debrided, clear of loose epithelium and necrotic tissue, and dried again, and then a small quantity of glue is applied there. The application can be done with a very fine needle, like a 30 gauge needle or a small cannula, or you can use a blunt instrument like a back of a plastic spatula or any blunt instrument. Care should be taken to prevent to apply too much of glue. If there is a perforation, too much of glue can spread intraocularly, which is not a good thing. And once glue is applied and it polymerizes into a solid structure on the surface, it has to be covered with the contact lenses to prevent patient irritation. Mainly, we use cyanoacrylate glue when there is corneal thinning or descemetosy, such as in cases of persistent defect makes melt or ulcers with melt. If the perforation, which is corneal perforation, which is smaller, less than 2 millimeter, when there is a lamellar laceration, we can try it small. In conditions like Murren's ulcers, blebs which are leaking, for temporary tarsography, and even for wound closure, skin closure, we can use cyanoacrylate glue. Now, a few examples here. This is a gentleman who has had an intracranial surgery done with persistent lag of thalmos, thinning, and descemetosyle. And so the first step here is, this is the most, I would say this as the most important step before applying glue. This is to debride of the unhealthy necrotic tissue and epithelium away from the area of interest. So these cases, what I generally do is, once the necrotic tissue is excised, the epithelium is also debrided slightly outside or more than the area of involvement, and then the glue is applied. Here, I'm using the blunt edge of a PVA sponge, which is dipped in the glue, and then it is gently applied over the area where we want to apply the glue. And it, as you can see here, it immediately polymerize or to form the hard glue. Once it is done, place the bandage contact lens. So this is another case of a small corneal perforation. This is just to show another method of application. Now the first, again, everything is done here, and this is applying the glue using a small cannula. A small drop is applied, and then you wait it for to polymerize and solidify. Once that is over, put the bandage lenses. Now this is a picture immediately after AC reformation and glue, the first one. Now one important point when to remember when there is a perforation is that in corneal perforation there will be aqueous leak. So before applying the glue, this leak has to be tamponated, and usually we do it with the air in the anterior chamber. Once the air blocks the area of perforation and prevents aqueous coming onto the surface, we can you should dry the area and apply the glue. And then this is how the cornea looks after glue removal. The eye or the cornea is tectonically stable now. Now, advantages of cyanoacrylate glue is that it has got a better bond strength than the biological adhesives, longer tissue retention time. There is no risk of transmission of any iatrogenic infections, easy to use and monitor, and it is cheap and easily available. The disadvantage is poor biocompatibility. It induces inflammation and invites vascularization. And it can be used only on the ocular surface and cannot be used in any other, or cannot be used intraocularly, even if required. Now, coming to biological adhesives, what is available now is the fibrin glue. It is nothing but basically a coagulation or clot which is used to stick tissues or other things onto the ocular surface. Pooled human plasma is used. Then there are modified tissue glues which incorporates antibiotics and other agents. Autologous blood can be used, from which the fibrin can be harvested, and recombinant fibrin glue is what is in developmental stages. Now, the advantage of the commercially available fibrin glue is the addition of aprotinin, which is actually an enzyme which delays fibrinolysis, and thereby it increases the duration of action of adhesive action of this glue. Now, the only problem is aprotinin is actually derived from a bovine source. Now, this is how the fibrin glue comes. It comes in with 4 components: thrombin, into which thrombin powder, into which you have to add the calcium chloride provided, and then the fibrinogen, into which you have to add the aprotinin, and this has to be incubated at 37 degrees. The company actually provides a fibrinotherm with which this is the temperature is maintained. Indications for biological glue is to actually to stick any of the biological tissues on the ocular surface. Can be used in sutureless pterygium surgery, for ocular surface reconstruction and stem cell transplants, conjunctival closure after surgery as an adjunct treatment in cases with epithelial ingrowth after LASIK, in lamellar keratoplasties, in corneal perforations, either directly or as along with amniotic membrane, closure of cataracts in sections, and it has also been described in sealing of anterior capsular tears in lenses. This is how it can be used to fix the conjunctival autograft after pterygium excision. Unlike the Diploject system, which is supplied with the TCL kit, what is better is to use both components in 2 separate syringes. Here, both the components are actually placed onto the bare area. Or another technique is you can place one component on the bare sclera and another on the conjunctival graft, and then it is slid to the bare sclera, stretched to match the defect, and then once this is done, the next step is to nicely iron out with a blunt instrument, so that a firm adhesion is formed between the graft and the sclera, and also the excess of the glue is actually ironed out of the interface. Another use is to show how it can be used to glue multiple layers of amniotic membrane in a case of PED with melt. So this is the first layer being glued. Again, it is glued into the area of the most thin part, and then the second area again glued onto the top of it. the excess is trimmed off. Then another layer, third layer, to glue it on to cover the entire defect. After this, a large amniotic membrane can be used to cover the entire cornea, and a prelimbal running suture can to keep it in place, and then a bandage contact lens place. So this is how the final healing has occurred. And this is another case of HSV with the similar to HSV keratitis resulting in thinning and multi-layered amniotic membrane. And this is a case of chemical injury where we have used multi-layered amniotic membrane and rehabilitated the patient. Again, it can be used for lamellar keratoplasties, also especially small graft and thin graft. The thicker graft, you may need to have a few anchoring sutures along with the fibrin glue. Now, another major advantage or a condition where management has really changed or helped us is ocular surface reconstruction. This is a case of acute chemical injury. As you all know, first step is to remove all the devitalized tissue, and then you cover it with an amniotic membrane. So once the necrotic tissue is removed, amniotic membrane is placed on the surface. I generally take a suture along the lid margin to anchor the amniotic membrane first, and then the fibrin glue is applied onto the surface, and the amniotic membrane is gently spread across and nicely ironed out on the ocular surface to achieve a good adhesion. Another use is to anchor the mucous membrane, oral or buccal mucous membrane in various conditions. Here it is for a lid margin keratinization in Stevens-Johnson syndrome. The first step is to excise keratinize. The mucosa is harvested and it is thinned out to remove all the subcutaneous tissue. The mucosa is again sutured along the lid margin, and then once it is secured to the lid margin, it is trimmed to fit the defect created, and then fibrin glue is applied to fix the graft onto the lid. So another indication is to fix the sclera in various conditions. In cases like staphyloma, once the staphyloma is reduced, you can actually use this fibrin glue to stick the scleral patch onto the surface. But here it doesn't produce enough tensile strength to keep the sclera flat. So we may have to take few anchoring sutures to hold it in place. So biological adhesives are basically biodegradable and flexible, and so can be used under living tissues. It has got very low inflammatory potential. In many cases, you can or one can avoid using sutures. So the patient is much more comfortable and healing can be rapid. Can be used to fix amniotic membrane, lamellar corneal button, sclera, Tenon's conjunctiva. Again, as I mentioned, it may be sutureless or minimal sutures. So reduces surgical time, postoperative patient comfort is much more, and avoids suture-related complications. The disadvantage of fibrin glue is the low tensile strength, and it is quite expensive. So causes of failure of a biological adhesive is the severe shearing force of the lid movement, which can pull the graft, either amniotic or conjunctival autograft from the side. The hocile ocular environment, which means the excessive inflammation can cause rapid degradation of the glue in the interface, causing the graft to dislodge. And in very large, thick graft, it may not work well. So to compare between cyanoacrylate and fibrin glue, cyanoacrylate provides good tectonic support. It is quite cheap and easy to use, but induces inflammation and vascularization and can be used only on the ocular surface. While fibrin glue provides excellent adjunct in various tectonic procedures along with various tissue grafts, but has got low tensile strength, is quite expensive, difficult to prepare, has got less inflammatory potential, and can be used intraocularly also. Thank you.
Thank you, Dr. Vinay. It was covered very well, both the cyanoacrylate glue as well as fibrin glue. Would like to have comment from Dr. Gautam Parmar.
Thank you. Good evening, all. And first of all, I would like to thank Iskeris for the opportunity It's always an honor to be invited as a panelist here. So, as Dr. Sinha sir rightly said, that Dr. Pillai is covered the topic very lucidly, covering all the aspect of the use of glue in ophthalmology. So nothing to say, but just from my side, basically we are basically tissue adhesives are indispensable part nowadays, especially in the emergency conditions. So and the use is also expanding day by day. So for the two basic purposes, we are using tissue adhesives. Like first one is to paste a tissue like MMG or amniotic membrane or conjunctiva in pterygiums, and for tenons also. So for the adhesive purpose, the use of fibrin glue is excellent. I think we never use the cyanoacrylate because it's a synthetic substance, so we can't use it in between the surfaces because it is not a biodegradable tissue. And instead of that, fibrin is a biodegradable tissue. So for pasting anything, we always use fibrin sealant. And for sealing a perforation also, now currently we are using fibrin tissue only with superimposed with reinforced with the sutures. If we like for sealing a perforation, if we simultaneously use a tenons, which is, I believe that it's a boon tissue for us because its availability as well as its autologousness. So if we use this tenons along with the fibrin sealant with reinforced with these overlay sutures, we can seal any type of perforations, because mainly perforation, when we talk about perforation, say about 3-4 mm perforation, the perforation is actually 1 to 2 mm. But the thinning of the surrounding area, that is a considerable thing. So what we prefer nowadays is multi-layered tenons application, because we can, I find that we can make sheets of the tenons also. And if we feel that small perforation with a small tenon tissue first with this fibrin sealant, and then we use multi-layered tenons to fill that thinned out area, and that is reinforced with a overlay suture. So this will seal any type of perforation. So nowadays I completely obsolete the use of cyanoacrylate in our practices. We are using very few occasions the cyanoacrylate. Mostly we are using fibrin sealant with the tenons with reinforced with the overlay suture. So this is from my side.
Thank you, Dr. Gautam. Point that needs to be discussed actually, that you said that we hardly use any cyanoacrylate glue, we use fibrin glue. There's one major concern is that if there's a small fistula, and if you're using glue, you have to spend a lot of money. So the cost is a concern, and cyanoacrylate glue can be very cheap and can easily cover the fistula. That is one thing. The second thing is there are some people who advocate the use of even Fevikwik in such fistulas. So any experience of Fevikwik in such cases? Because I don't have, and I don't know, Namrata, do you have any experience, ma'am, of Fevikwik?
No, I don't have any experience with Fevikwik, Rajesh.
Yeah.
Only cyanoacrylate glue.
Yeah, in
Fibrin
one of the
glue.
webinars we had this this came up, and it was told that it is very useful, and they have been using it for quite some time. It works well, and the cost is absolutely negligible.
Yeah, Fevikwik is a cyanoacrylate derivative. I don't remember which one, but then the problem was
It's
it
not
induces a lot of
N-butyl, but
inflammation.
yeah, it is.
Yeah, it induces a lot of inflammation compared to the one which we are using. I've never used it, but then yes,
even
that's
for
what I.
that matter, cyanoacrylate glue also induces a lot of vascularization. Wherever you use it, it just drives in vessels there. So that is the flip side of it. And then the theory, the thing is, flip side of it, this is okay, you will seal a perforation at that time, but you're probably creating a bed for a high risk graft rejection if you do need to do at a later date. So cyanoacrylate also, but then that is the best that we have and the cheapest that we have.
Yeah. Another point that I would like to know from Dr. Vinay is that if you put a fibrin glue, a small droplet, or even from the back surface of the applicator that you showed very nicely, do you if you keep doing serial ASOCT, you do get to see that there is some healing going on, right? That gives you an idea. Do you remove it after some time, or you just allow it to fall off by itself?
I generally remove it. Either it falls off or remove it. I don't remove it before a couple of months at least. I mean, again, it depends on the indication. If there is a frank perforation for which I have done a cyanoacrylate glue, I wait. I mean, I don't know how to say this, but then in those cases, as Madam said, it does invite vascularization, but that is my endpoint. I wait for the vascularization to come in those cases. Okay, once I see that you get kind of vascularization going around the glue. Okay, once I get that kind of vascularization, then I know under it has vascularized. Whatever perf or whatever is there, it is sealed. Then I remove it if it has not fallen off by that.
Sometimes the patients, they come to you, for instance, if you do an SJS kind of a case scenario, and you get a lot of them and they don't even have tears, so they'll complain of foreign body sensation, gritty sensation. So I think after a month you can remove it and it would still actually remain the same, provided some sort of a scarring tissue has creeped in below it.
And you very nicely showed that you use 2 syringes rather than
What about sorry, yes, come
Diplo. Yes.
No, carry on.
Yeah. So actually we also use 2 syringes only. So I would like to have opinion of everyone here, that any one of us who uses this Diplo syringe kind of a thing. Like we use the 2 component in 2 separate syringes. And I think Dr. Namta also does the same.
Yeah, I also do this.
Dr. Rishi is also nodding. He also does the same. So anyone else who
does differently?
I too use separately because it gives me some extra time to react.
Okay.
I think the one important also point can be that once we're sharing the glue between cases, it's important to change the syringe at the end of the case. Before you start the next case, sometimes you're pushing it and it's blocked. So once you finish the case and you're using it for another case, the hub should be changed, the syringe should be changed. Sometimes people forget to do that and then it just doesn't work.
I don't take the whole 1 ml in the syringe at all. I just take 0.1 or 0.2 ml for each case and discard whatever is remaining. The bottle, the rest stays in the bottle. That is what is reused, not the same syringe.
What about Vinay? Can I ask you a question? What about the drape patch technique? Are you more comfortable with the drape patch kind of a technique where you put where you cut those drapes into about 3 millimeters, punch them, and then put the drape there and then
never used
put the glue? Because I know
I've never used it.
Okay, so that kind of works well if your perforation is a little more than say 3 millimeters. You can put those contiguous drapes there, so it will cover the whole thing.
I have actually used a bandage contact lens for larger perforations. I cut the bandage, BCL, to be slightly larger than the area of perf, keep it there, and on the top of it, put the glue. So it stays there, and then it kind of falls off after a few months. By then it scars off.
Sir, I think we are again going to have shortage of corneas now. And so these cases of perforations are going to come all over the country, not only in RP Center. So what do you suggest? should be the way forward. I mean, we are not going to have corneas, and with great
I think-
difficulty, in fact, the iBanking had moved away a
Yeah.
little bit forward, and now it is again gone at the back.
But I think even the distribution of tissue is going to be difficult with so much of containment zones coming up. State may not allow. Then you have to depend on your local area only. I think this is the time we should coordinate with each iBank in the city, try to have a pool for especially for emergency patients. So I'm not sure if we have preserved some glycerin preserved tissues in a recent past. That was a savior for when we had a first and second peak, especially second peak. We did have around 40, 50 of those tissues. So that can save the day for many patients, even for therapeutic keratoplasties also. I think there has to be some sort of understanding between various iBanks, then make a pool, distribute these tissues. Otherwise, the various technique people have used can be restarted. People have used TNED's patch, very successfully in these cases of even a larger population also. So that is one innovative thing which people have used, and that has worked quite effectively also. I would suggest at this stage, I think we should have a common pool of a therapeutic tissue, if not optical tissue, because optical will be difficult. But I'm pretty sure we would have some sort of a cornea coming also. If we are, this time is not going to be total lockdown, so people are still working. So there won't be a total, scarcity of tissue. But Binay, I just want to clarify the point which Namrata talked about, putting that drape punch in a perforation which is more than 3 or 3.5 millimeter. So how does this corneal tissue heal in such cases? Because you have a tissue there. Over that, there'll be some fibrous membrane growing, Namrata, over the between the drape and the glue.
Between the drape and the glue, yes, it is
Underneath the
under
drape,
the
I
under it, sir.
underneath the drape, how would it grow? You have a aqueous hitting that area.
Yeah, so underneath it grows, and then just like you remove the glue, then sometimes you have to remove those patches also after it has healed completely.
It's cast down and kind of a vascular membrane grows under the.
So you have to put some strengthening procedure subsequently also, because this will be a
only
thing.
this is this is only for interim, sir, interim period then.
Because if you have a slightly larger perforation, it would be better to do some sort of patch graft in these cases, rather than leaving for a glue in these cases. Maybe for emergency purpose.
Correct.
For a smaller perforation, yes.
There was a very interesting paper. I was listening to one of the presenters in one of the state society meetings, and they had presented that they used the scarred cornea, wherein they did optical keratoplasty. They preserved that cornea and they used it for therapeutic. Yeah. So
Rajesh, you don't have to go so far, because people are now restructured the pig heart. So why don't you use, all these other, like a xenograph. Now again, that's a time.
True.
Rather than going for a very costly synthetic tissue. This may be another one. We can totally, kill the antigenic component of that tissue from either pig or whichever this thing, and use that cornea. Maybe that will be better than other tissue which are preserved for a very, very long time. So I think some of you should work with that area also now to revive the old concept.
Smile lenticule is also something we've used in a few cases where we had a small perforation and a smile lenticule was used, and that
that's
worked.
pretty thin. You will have to duplicate it.
Layers, yes. When we was just a couple of cases we tried it, and just the layers of it, and it seemed to work well.
I think the point Rajesh was highlighting is, not a bad idea to preserve the, why throw those corneas, which are scarred? They might work out anytime. Maybe the same patient comes back with a totally decent graft and you have to put the same thing back. It's a good idea. I like that idea.
Only thing is, for our cases, whenever we do a full thickness keratoplasty, then you send the sample for histopathology. So half of it for histopathology, half of it for microbiology. That is the only problem.
Never know. These pandemics will keep coming, every year. Then you'll require some sort of preserved tissues. It's not going to go off in next 5-10 years.
I thought it is going to go off now that I've got it already.
That's only for a few months.
I was feeling happy about it, actually.
That's only for 6 to 9 months. Because everybody has got again.
Yeah.
Not going to save people. In fact, those people who got infection earlier, they got reinfection faster. Maybe that it indicates they've been exposed to these viruses. Maybe they're working in that area like medical staffs, or their immunity is really down.
So any comment from Dr. Rishi?
Rishi is not spoken.
I know his throat is not good, but we cannot wind up before you say something.
I was using hand gestures and my head.
To say yes and to say no. In affirmative or in...
But yeah, excellent discussion. I think both Dr. Bhanati's talk and Vinay, excellent, as well as the comments that came from Chintan and Gautam and the panel. If I look at astigmatism after keratoplasty, I think I've probably dealt with more astigmatisms than I've actually dealt with keratoplasties. So the astigmatism just goes on and on. It's a never-ending game, and so I have a gamut of videos and everything that has been described I've done, right from wedge resections to this thing. The 2 or 3 key elements that one must look at. One is, of course, as Chintan also highlighted, is the intraoperative. What can you do? One is, of course, the use of a Fleringer ring. We know that aphakics and pseudophakics will have more disparity between the roundness of the graft that we have punched and the ovality of the definition that we have created. And that disparity between the increase in the ovality leads to a substantial increase in the amount of astigmatism. That's been well documented. The other thing is the use of the trephines. We are still using trephines which are open. And remember that open trephinations are going to create a much greater ovality effect than a vacuum trephine. And it's important to counterbalance the pressure force and the suction to try and bring it up so that you don't actually create a distortion on the globe. And a Hesburg-Barron becomes then the standard for reducing the amount of disparity. So that, I think, is one important point. The host graft disparity, again, in terms of sizing, is important. And once we have done with the intraoperative bits, you use the Fleringer ring and all that, and we've ensured that we've got a good appositional closure. When you're doing the final adjustments of the sutures, you must take off everything. The speculum, the, whatever, if you've got any bridal sutures, ensure that there's no, this thing, you've inflated the chamber to the appropriate IOP. That's when you should actually do your final this thing by picking up the loops and making the adjustments. The other take-home message is that if a suture doesn't look right on the table, it's not going to become right afterwards. So that's something that I've learned. It's been taught to me millions and millions of times, and it's something that I do. So I don't mind, after finishing everything, I'll just tell the anesthetist, if we're doing it under GA, give me another 10 minutes and I'll just replace the 3 stitches I don't like, rather than to leave them for them to give me trouble later. As far as suture out astigmatism is concerned, which was, I think, the major talk, the thing that one must look at is, do you want to flatten the steep axis, or do you want to steepen the flat axis? That's extremely important because it changes your entire approach. So we must look at what is going to be the spread of the final refractive error in terms of what you're going to create. You don't want to create somebody with a -7 just because the patient had a 47 cornea to start with, and then you took out the 56 diopter walas, and then you created this whole thing. So this is the kind of thing that one must look at, and there the compression sutures aspects come in. LASIK works beautifully, and I think that two-stage LASIK is a great thing, except that in private practice, it's not always easy to convince people to get these procedures done again and again. I think institutional are more privileged in that sense. The patients that may understand that much better. So what I do as a thumb rule is to reduce the refractive error by 50%. And when I will create the flap, I will not create the entire correction that is required, but I will do half of it. And that does bring the total quantum of the refractive error and the astigmatism down to areas where I can then provide them with glasses. So I think that's about what I'd like to say on astigmatism. These astigmatisms tend to come back. So if you follow these patients after LASIK and after these grafts, you follow them up for 10 years, and I have 3 or 4 cases, the astigmatism actually went back. It went from 7 diopters to 3 diopters in one patient and went back to 6.5 diopters in 5 years. So, so that is all, easy to say and discuss, but practically it's very tough. On the glue front, I think I'm in complete agreement with everything that was discussed. I think it was very nicely, both the discussion as well as the talk was excellent. For larger perforations, my only caveat, I prefer to use that little drape and that thing, and I use the back end of a Miracell sponge, a little bit of ointment on it, and I punch out a small little area from the best ones are usually the cover of the sutures. So if you have the imported sutures, you can punch out a little bit of plastic from that. That is by far the thinnest material that you can get, which is also sterile. And then you can use a little bit of, just touch it with an antibiotic ointment and tip it on that. And then you upturn it, put a little bit of Sinocrate on the top and just go whap, just the same way as was shown by Dr. Vinay. That was a very elegant technique, and that works very well. Only thing with larger this thing is the concern of it finding its way inside. These chambers are usually flat. So try and see if you can create a side port, maybe put in some viscoelastic, maybe put in a little bit of air, and then try and see if you do the, otherwise you'll stick the iris to the back. It's happened to me. So, and that is then another nightmare. And then removing these is the biggest nightmare. Because when you remove these, you are not sure what you're going to find underneath. And very often you'll just rip off that tenuous healing that was happening. And then you say, why did I even have to touch this? So my take now on it is leave it alone. If it has to come off, let it come off. That's it.
Thank you, Dr. Rishi. It was a very nice webinar, 2 important topics that we discussed. So big thanks to all the speakers and the panelists, and of course, our own office bearers. Sir, would you like to say anything? Concluding remarks? Okay. So thanks to IPCA for supporting this. Thanks to our IT team by Bageshwar, and of course, our own staff, Mr. Anil Kumar. So big thanks to all of you, and happy Makar Sankranti, Pongal, and
all the other festivals.
Yeah.
Thank you.
And good night.
Good night.
Thank you.
Good night. Thanks, everybody.